We are about 2 minutes after the hour. We are recording this session. This is a 30-minute session, so I'm only gonna we're gonna get started. I only want to wait just a couple minutes, and then as people file in, they can always listen to this afterwards for any parts that they missed, since it's very short. But I do want to welcome all of my good friends here that I just enjoy so much talking to, and so honored that you're here to do this session with me. But Christie Musser, who is the Senior Director of Virtual Care at St. Luke's University. And let me put this up as we go. And Carol Yarbrough, the Business Operations Manager for the Telehealth Resource Center at UCSF, and Amanda Buonocore, who is the Coding and Reimbursement Manager for Northwell. It's just like Marvel Comics, Justice League of reimbursement people here to totally, if it was all women. Okay, I think I got
like that. Coding Justice League.
Right, I got my screen share got paused. I'm not really sure why. I'm gonna try back, I think, because we do have some background recording happening. So I think maybe there was a little bit of disjointedness on technology there. So sorry. So we will be covering these topics really quickly. But all of the folks will join in. And again, if you have any questions, please feel free to ask any of your questions in the chat. We will be monitoring those and try to answer them as much as possible. Okay, let's get going. Is a portal email worth it? These are scenarios, I believe, where we're getting a whole bunch of emails physicians are, and what should we do with that? Christie.
So is an email portal worth it? Yes, if it's structured correctly, I think it is worth it. Getting to that point where it is structured in a way that makes sense and everyone understands it, that's the hard part. So the concept is great in theory, but you really have to work with your EHR, with your coding experts, with your billing experts, and with your providers to get them all on the same page. Make sure you have a solid, airtight workflow. And then you also have to figure out how to message this to patients. That's one of the most difficult things that we're finding, is that, we're now communicating with patients in a way that previously there was no bill for. So how do we structure this and let them know it's a billable service, and let them know that there's value in this service and that's why it's billable? So yes, I do think it's worth it. I think that there's providers, including CMS and some Medicaid providers, that are really coming along and recognizing the value of this. But the structuring piece is important to do if you want to make it successful.
Can I add to that?
Please do. I was going to point to you. Go ahead.
I think it's also important to acknowledge and understand the bundling rules around this, and always know or educate the physicians when to convert the service. So there may be occasions where the emails, so it's essentially a service for the next 7 days that only goes up to a certain amount of minutes. If that time is being exceeded, there's always the possibility, or you feel that the communication is more warranted as a visit, it's easier to say, hey, we should convert this to a visit and do the visit, because once you do all the email exchange and the visit, only the visit, the E&M visit, would be reimbursable anyway. So if you do find that a patient is consistently emailing additional questions, just acknowledge over the next 7 days that that's going to be the one code that you have.
And have a process in place to catch that, because if you bill both, you're going there comes the denial.
Yep, absolutely. Good point. Okay, what is the billable service? What is billable on a telephone call?
Wow, how much time do we have? So telephone calls. So telephone calls, there was actually a couple of one code that Medicare, CMS put out pre-pandemic, that was called the e-check-in. And that was actually something that could be completed via telephone call. And so it was for some of those quick discussions that resulted in some sort of medical decision-making or triage service. So that was billable. Pandemic comes along. Now everything is billable with a telephone call, right? But the question comes into is how is the insurance company paying for telephone calls and recognizing it, and under what circumstances? So what we're seeing is that phone calls are still billable, even under Medicare, under the waivers as they currently stand. When those waivers end, the pre-pandemic e-visit check-ins or the e-check-ins will continue to be payable, but what's payable on those telephone calls remains to be seen, payer by payer. So it's going to definitely be one of those things you're going to have to watch payer by payer. And we can definitely say that behavioral health has approved telephone calls as an acceptable method of a visit if the patient doesn't have the access or it's their preference to use the telephone. So so we are seeing it in behavioral health more so than others. There's been no definitive information on that. And I think there's a couple of questions coming up,
I was gonna say there is, yes.
which I expected.
Can you
Yeah.
explain bundling with telephone calls? So,
I'm
so
already
I think,
she answered that, Michael.
well, I can add, right? So I think, you know, if we look at telephone calls during the pandemic, they're butchered. It's butchered from what the code was officially created as, and the reason why you used it, and we never got reimbursed beforehand anyway. So during the pandemic, it initially came out that you could use the virtual e-visit codes, then they converted to saying you could use the telephone visit codes, which were by guidelines, patient-initiated services for established patients. Then they converted it to allow you to use it for new or established patients if that patient did not have access to audio and visual technology. So you're technically working within two guidelines. You can use a telephone visit for an established patient who is patient initiating the visit, or you could use it for a scheduled visit if the patient gives a reason in why you can't use or they don't want to use audio visual. One thing to keep in mind is it's a visit, right? So you need a reason and you need an ending. The trickiness comes into where you use prolonged versus where you use a telephone call, right? So if you have, and then it's going to get even trickier when they get rid of the prolonged codes. And then with the new prolonged codes, they kind of eliminated for CMS a day, the non-same day prolonged service code, which was related to a visit. So it all gets very, very complicated. And I don't know if I even answered the question. So the bundling is if you have a new visit with a new reason under the public health emergency and you did a telephone call on one day, you're doing a telehealth visit a different day for a different reason, both can be submitted. If it's the same reason, you're looking at your prolonged service codes, not your second visit codes. And for the prolonged service codes, there's a time requirement. You have to meet an additional 31 minutes related to the prior service. So
I would also say there's a bundling component of there that if the telephone call escalates to an in-person service that day or the next available, appointment. So basically, if you're saying, listen, we need to end this conversation, you need to come in or you need to get to say, then that would be, the telephone call would then be null and void, and you're going to build the higher, more appropriate in-person or alternate service.
Yeah, so we always say if the decision is made at the end of the call that you can't make a decision without seeing the patient, don't bill the call.
Correct.
Yep, that's why I have all of you here. First of all, let me explain why I took the slides off. I've got minions behind the scenes who are amazing people, and they're telling me that they could not see your face. So I wanted to make sure that everyone could see your faces, and all of our slides just had questions on them. So I felt like your faces were important, more important than the questions. Okay, so moving on, I hope Michael got your answer to that question. Give us a thumbs up or whatever to indicate yes on that one. Although Carol might
Yeah,
in the chat.
it is clear. It hurts our brains too. Yeah.
Yeah, yeah.
Right. Right. And as you can tell, this conversation was meant to be just that, a conversation. So here's another one that we get all the time. How do I avoid the surprise billing situation? Because we do a telehealth visit and then maybe we have a copay or deductible, stuff like that. So what are your thoughts on that? Carol, you can pick that one up.
Yeah, I'll take that one. So you should always obtain patient consent prior to initiating any kind of e-visit. For telehealth visits that are audio visual, you can get an annual consent, file it away, and then pull it out and say, see what you signed? It's not surprise, you know, here, let me send you it again to realize that you have a $25 copay, or you've got $1,000 deductible that you have to meet before the copay just gets to kick in.
What about AVNs related to that then? Should you do an AVN also?
Yeah.
Yes. Yes. So you need an ABN also.
Yeah.
At UCSF, they do have telehealth audio visual written in, and I'm not sure if we have e-visit in there yet. But the thing about that is when you're doing an e-visit, you need to be consented every single time. So when Christie was talking about the portal email messages, the way we have it set up is that a message flashes up and says, you know, you're emailing your provider through the portal. This might turn into a billable encounter. Do you wish to proceed? And person says, yeah.
Mhm.
So you've given consent.
Yep.
That's
key.
Yeah. And so for things like e-consults as well, that's provider to provider. That has to also be consented each time as well, because if the patient hasn't seen the provider that was the e-consultant and they get a bill from a cardiologist and they're like, I'm not slipping that far. I swear I just saw the primary care provider. Of course, I wouldn't know. I've been so distracted in the last couple of weeks. I'll just pay it. But then it'd be like, oh yeah, I did consent to have that e-consult sent over so I can get an answer about my cardiology condition prior to seeing that cardiologist who is not available for another 6 months. So
depending on your organization and the risk tolerance of your organization, you may want to add that piece into, the general consent of the hospitalization. So every time they're hospitalized, they're consenting to the potential of a e-consult, right? So that's dependent on your organizational, risk tolerance as to, because let's face it, no one reads the general consent.
Except for us.
Yeah.
Apple terms and conditions. None of us reads any of that either.
Yeah, but you do have it. I mean, it is that backdrop of potentially avoiding any legal issues.
Yeah.
Tie a bow on that.
Definitely in the general consent.
Yeah,
we had we've had people fight us who were physically in the office, or physically in the hospital, saying they weren't there. It's like, well, you were there. So if it's not in the consent for the e-visit, just know that they'll probably also say.
Yeah, they're like little miniature contracts.
Yeah.
It's not in the contract. It's not part of the deal. If I didn't consent to it,
exactly.
I'm not paying you for my plumbing. Okay, next question.
Okay, next question is we had this debate before we started, but on the on-site lab non-provider question, does anyone have any or better way to describe that question? And then
I can answer that one super quick, and then Amanda. So we did have the thing where patients would come in to get their vaccinations, like well children visits. Patients are on site, provider is off site. So you get your vaccinations or you get your lab blood work. You don't get to charge any kind of facility fee other than You're going to get charged for the 88 code, 88XXX or whatever that is. And then when the lab person does the reading, if there is an associated professional fee with that particular lab code, when the person does the reading of that, you'll get another bill for that. But if the patient is on site, you had to go in to get certain things done, providers off site, you bill at place of service 02 because patient is not at home. The place of service 10 is for when the patient is receiving services at home. And then during the public health emergency, the facility can bill Q3014. I think because there's, or at least the transmission fee here in California, because that's 26 cents. That's T1014 that you can bill for that transmission. Potentially, I mean, I do think they could bill the Q3014 because somebody's not on site and there is an originating site somewhere that's not being charged for. So hand it over to the rest of y'all.
What are your
I
thoughts?
think you got it, Carol. I'm so confused where the patient is.
I know, right?
Patient is on campus.
I think in the question, it says lab. Are we assuming they're in the lab?
I think that's the situation. They're in like an offsite lab, like a reference lab.
Okay.
And then the question is, they have a visit there, like a telehealth visit while they're in the reference lab, right?
Okay. Yeah,
I'm sitting at Quest on my phone.
Yeah, then I agree with
Correct.
Carol. Then it's 02 for the physician who's off-site doing the telehealth visit. And it's the lab bills the lab.
The lab as they would.
Reader bills the professional reading.
And if the patient happened to be at home in that scenario and we don't understand that question at all, it would be an 02 or 10 for place of service.
Or it would still be 02 until April 1st.
Oh, that's true.
Unless everything gets
there's a
extended.
commercial that's already adopted it.
Unless the PIT extends. Okay, so the next question is the one that you guys get all the time, and maybe this is more process question, but the physician's asking, what can I bill?
Yeah, that's a good one.
You take that one because I know you're
Go,
passionate.
Amanda.
Yeah, so, and we always like to explain to the physicians, telehealth is a replacement to the face-to-face component of services you provided in person, right? And it's only for a set limited amount of services. Converting to an audiovisual platform doesn't necessarily now make things billable that weren't billable before. It may give you an opportunity to do services that you weren't able to do before, but it doesn't necessarily come with new codes. So we always say, well, what are you doing now? And let's look at that. And then we'll see if there's opportunity in between. A lot of the lower level, like telemedicine codes, like the e-visits or the telephonic are not additions to a visit. They are essentially catching low-hanging fruit that you weren't billing for before. So if you have a patient that is out and, calling and saying, oh, I'm having some issues with my medication, I want to change it. Can you reduce it? I'm going away on Monday, and you send in the scripts. You guys have a conversation around their symptoms and a decision-making. That's something you might have not billed for before. That's something that, based on the time frame that patient will be around, it might make sense just to bill it as a telephone visit and making them come into the office. I sometimes, I'm like the nicest coder patient. So when I email my doctors, like I already decide I don't want to come in. So I'll send them an email saying, here's my symptoms. Here's what's going on. Here's what I need the answer to. And by the way, you have my consent. And if you would like, you could bill 99421 or 994423, So yeah, but the one piece that's important in those scenarios is getting the consent. And I know that pre-pandemic that was a little bit of a hard conversation for the doctors because they felt this is something they had always been doing. How did they communicate now it's going to cost potential copay from the patient? And that, that's more about explaining to the patient. I think the pandemic kind of accelerated those conversations and allowed that opportunity. But outside of that, we get a lot of remote patient monitoring came out. How do I do this in my practice? Well, who do you have to monitor? Whose data do you need? So yeah.
I prefer them to ask the question or say, come to me with, this is the service I provided.
Exactly. Yeah.
What code would be appropriate for this service?
Yeah.
Sometimes we can give it to you. Sometimes there isn't, an appropriate code, but typically we can, work with something, but that would probably be, you want to do this, you bill for what you're doing. So it's really, we'll bill for what you're doing, and that we have to figure out what that code is.
Yeah.
And I think it's a conversation. I know from the conversations that we've had with our clients that, you start to talk about what they're trying to accomplish. I always like that. What do you, I know from a clinical service, what are you providing, but what are you trying to accomplish clinically? And then we can start to talk through this and figure out what it is that we can bill for in that accomplishment of the clinical service. We're getting a lot of great questions in the chat. Bless Carol, who is answering them. A couple of, that was a good question. And we're also getting questions about whether or not this is recorded. It is recorded and it will be available on our website, like all of our other webinars are on our website right away. So, and you can see those at any time, they're all free. We did have a quick question to ask about whether or not this was what the question was on that last one. And it was really just how to better ask a question about what can be billed and what can't be billed. Okay, so let's talk about what do you think is going to be the future? So I have had a couple of clients that are worried about, they're not getting any denials right now, but they're worried they're going to get an audit and that they're going to get a take back because they feel like they're trying to do what they can do right, but they're not sure if they are doing it right. So what are your thoughts?
I'll start with that one. I'm sure we can add to it, but it's not going to, although there might be a focus on telehealth, right? It's not going to be any different than your in-person audits. They're going to look at what you're doing. If there's something that seems amiss or something that's not right, they're going to start with education, right? We don't automatically jump to the orange jumpsuits. So I don't really think that there's going to be a major shift in the way that audits occur now. And if you're trying, and I think the important piece is if you have this written in your compliance or you have policies written around what you're doing and how you are trying to ensure that what you're billing out is appropriate to the payer and appropriate to the service that's documented. If for some reason a payer comes back and says, no, that's not the way we do it, okay, then we correct it. You can at least show them this is why we were doing it. You have logic behind it. And overall, as far as telehealth going away, I think it's going to evolve. It's not going away.
Yeah. And I think that I would add to that I also think that if you're worried about this right now, we're not selling services. There's certainly people that you can call to, take a quick look at what your claims are and how you're processing them, look at a percentage like you would with any kind of charts and things like that to kind of proactively look at that. Any other thoughts real quick? Because we have one other question from a clinician.
Oh, those are exciting.
Yes. Okay, so last, we might have two if we have time, we'll see. So I'm a pediatrician. Oh, wait a minute. Did you just answer that, Carol, in real time? Because I see it going away. So we had an open question.
I did. I had to look up the time. It's a 99458. If she, go ahead and read the question, and then I'll defend my answer to Amanda and Christie like a thesis.
Okay, sounds good. I'm a pediatrician, spend 25 minutes on the phone with a child psychiatrist discussing the plan of care for my patient. Is this billable? And Carol's answer is if the other provider sent you a formal request for information and you replied verbally and in writing to the provider, yes, 25 minutes at 99448. Any disagreement?
Oh, did you say 448? I thought you said 5. 448, I agree with.
Yeah.
She said 99448.
Yes, interprofessional consult.
And then because Carol was so efficient, we can answer a final one. We're getting in that says, you're welcome on the last question, because thank you. In many organizations, are patients being told that their PCP, for example, is consulting with a specialist about their case? So secondary provider. Often if they are, this may happen during a visit or during an async exchange in the EMR. Are patients really aware that this is billable and they may be seeing a charge for this? And the question is that I'm in the state of Ohio, so we might not know state specific, but I think this is generalized anyway.
General.
Thing.
Yeah, you need to let the patient know, just like you would if you're in person. Like if you're going to consult with, let's say you're in the hospital and you're the hospitalist and you're going to bring an endo. Hopefully you're not going to surprise them with the endo doc just walking in and trying to explain why they're there. You're going to say, hey, I'm going to consult with endo and have them come in and see you. I don't think there's any difference. And from the literature I've read, and I think Carol will know more on this, patients are very receptive to this because at the end of the day, it's saving them, it's potentially saving them time and expense for actually a higher level consult with a specialist. So yes, it is a conversation that needs to be had. And I do think patients are receptive to it for the most part.
And really for inpatient, you don't have to consent because you've just consented to everything that's happening to you.
Exactly.
There anyway. There's no copay for individual, like, oh, I was in the hospital for 10 days and I have a copay for every 99233 that the hospitalist is submitting and every 99233 that the neurologist is submitting. That's just all like for like
what about it?
$75.
Yeah, there may be co-insurance. There may be co-insurance, but
Yeah.
the RVUs and the cost associated with these services is low that co-insurance is going to be nominal.
And true for ambulatory as well?
Correct. Same codes.
But for
As of
ambulatory, definitely
Have the
you are
conversation.
consenting to this because we're going to charge you some money.
Yeah.
But we're going to save you driving into the city again, and we're going to save you parking and waiting 6 months.
Yeah, I would just add, I mean, I know New York State Medicaid wasn't paying for any non-face-to-face services. So, look at your patient population, and during the public health emergency, they'll pay for it, but post-public health emergency, they had no interest in paying for any of the e-consults or the portal messages or anything like that. So if you're building it out of a clinic setting and there's different state guidelines, it may be a wash anyway. So
Medicare will pay for it though.
Medicare will pay for it.
Medicare will pay for it. And if you'd like to join us in advocacy on this, please do.
I love that. I love that pitch. Yes. And that's a great point. This is coming up all the time, right? With this idea of the e-consult question and what can I bill, particularly for those that are might be looking for business opportunities around that as well.
Absolutely.
On a day-to-day basis, people are looking at. All right. So do we have any open questions? I think we've answered them. We're right on time. Oh, that's amazing.
You're amazing with us.
I know,
right?
Yeah.
I kept you straight. I kept you any other final thoughts?
I would just add to anyone who's nervous about the future, in the final rule that came out, there were some codes that were put on temporarily, and nearly all of them were denied to be added additionally to the expanded list. And the common thread was there was not enough clinical data to support the addition of it permanently. Now, as a country, we've been given carte blanche for nearly 2.5 years. So if you're nervous of any of your business going away post-pandemic, I would focus on that temporary list and look at the areas in which you have business right now and start preparing your clinical information to submit to CMS as a reason to make it permanent.
Mhm.
Great advice. Great advice. Any other final thoughts?
Just stay the course. It's, definitely here to stay. It's evolving, but we're all in this together. It's new for everybody.
And we're
I
here to
love-
help.
Yeah, absolutely.
I love it. I love it. And then we also just thank you so much for doing this webinar. Thank you everybody for attending. We're trying to do these little short bits of information so you can just quick do that while you're eating lunch or eat lunch and watch this and then go back to work. We're also doing lightning webinars, which are only supposed to be 15 minutes long, and I think our last one was 20. So we're trying to just get little 15-minute sessions. If you have any topics that you want us to cover in those 15 minutes, please tell us. Also, just a plug for ATA, that's coming up in a couple of months, and they've also have a letter out for everyone to support around the advocacy point that Christie did. So thank you, everybody. Appreciate it.
Bye-bye.
Thank you. Bye.
Happy coding.